Okay, thanks Simone. It's an absolute pleasure to be here, and it's really nice to see some familiar faces from Peter McElroy work as well, so really happy to see you all. So I'm going to start my talk giving you a bit of education about nutrition and sort of what we know so far, what I'd go through with my patients, because I think it's a really nice opportunity to do that today, particularly for those of you that don't have access to a NET specialist dietitian, because there aren't many of us in Australia. And then at the end, I'm just going to touch on a little bit about my PhD research and some preliminary results that are coming through that might be of interest to you. So what are our goals in terms of nutrition and NET? And it's often good to come back to these in terms of why we actually look at diet and why diet's important. And some of these are similar for cancer patients generally, some are NET specific, but I mean, in general, we want to make sure your nutritional status is the best it can be, so you're maintaining a healthy weight, you're not losing lots of weight, you're not gaining lots of weight, and I'll talk a bit more about that. Optimising quality of life. So I think this is one of the most important things. Diet's not just about the nutrients we get from our food, it's also about how we socialise with friends and family. It's how we enjoy life by eating often. So there's a lot of different aspects that, you know, us as dietitians think is very important. And so I think when it comes to NETs and diet, a lot of people want to know is what is the best diet for me health-wise, but what also can make sure that I can actually eat with my friends and family and not have trouble. We know that in cancer, nutrition has a really big role in response to treatment. So the better nutrition is, the better you'll respond and recover from treatment, and it will improve your immune function if it's optimised. Symptom management. So not only does nutrition help control symptoms, it also might find that symptoms might actually impact how you're eating as well, and I'll talk more about that. I'll talk a little bit about the vitamins that are flagged as potential risks in NET patients as well. And the dietitian really has an important role in the whole care team in terms of managing NETs. So general principles, I've talked about maintaining a healthy weight, but what is that? So depending on your age, we look at body mass index. It's probably the most simple way to measure that, and that's measuring your weight over your height in metres squared, and that comes up with a BMI. Don't be too stressed if you're above or below a little bit of the range. It's really just a bit of a marker. It doesn't really measure your body composition or your muscle mass, so as long as you're around that healthy range, that's a really good thing. Generally, try and follow a high protein diet so you get lots of good range of amino acids through proteins in your diet, and make sure you get adequacy there. Eat frequently, don't skip meals. So if you're having trouble with eating, try not to go without eating for long periods of time. That can cause all sorts of issues, and potentially inadequate diet. Eat a variety of food. So I say to people, really nice colourful diet, lots of different fruits and vegetables, lots of different whole grains and those sorts of things. And try not to have too much of the nasty things which are high in salt, high in saturated fats, also sort of really fatty animal fats, and added sugar. Sugar isn't necessarily bad for you or your cancer, but it doesn't give you a whole lot of nutrition. So we tell people, you know, unless you're really trying to build your energy intake, you don't really need the excess simple sugars and table sugar. If you're feeling really healthy and you've got very little symptoms, a lot of NET patients are like this, just eat healthy. Don't feel that you have to follow any particular special diet. In terms of treatment side effects, so what we expect in terms of nutrition with these, and I won't go through them in detail, but just to give you a bit of a list, that the various different types of treatments that NET patients undergo can cause symptoms that can impact nutrition. Some of the key ones are surgery. So if you have surgery to your pancreas or your bowel, you can get malabsorption syndromes, you can get problems with diarrhea, and dehydration, so being aware of those. Some of your targeted therapies and chemotherapies can cause side effects for short or longer periods of time. I'll talk a bit more about somatostatin analogues in further slides, but certainly whilst they can improve your symptoms, they also do have their own side effects that might be considered. Very long list of nutrition-related side effects for NETs. You may have some of these, some of them might look familiar. As a dietitian working with NETs, I deal with all of these, and nutrition certainly can play a role. So carcinoid syndrome, this is probably one of the more complex types of symptoms or symptom profiles that patients undergo. So this is for patients that have serotonin-producing NETs, so NETs that produce a lot of serotonin that can cause those symptoms of flushing, diarrhea, abdominal pain, fatigue, wheezing. You may not have all of these, you might have some of these. There's a lot of complexity around these symptoms and how that might impact diet, so that's what I'm going to talk through a little bit. There's been a lot of talk about foods that might trigger symptoms, and I'll mention what some of those are, but not to say that we've definitely got the research and the evidence to say you definitely shouldn't eat that, you definitely should eat this. One really important thing that we do actually know from some of the literature is about a vitamin called niacin, which is vitamin B3. This is an essential vitamin in our body. We don't need a lot of it. Our body actually uses tryptophan, which is an essential amino acid, so another important reason to be eating lots of protein foods. What we get through our diet actually converts to niacin when we eat it. What it also converts to is serotonin. So if you've got a tumour that's secreting a lot of serotonin, less of that tryptophan is actually converting to niacin. So there can be that risk of deficiency in niacin. The research has shown in patients with Carcinoid Syndrome or serotonin-producing NETs, up to 45% might have a deficiency. And when I say biochemical, that means a blood test has shown a deficiency. So you may not necessarily feel any different or have any symptoms. Pellagra is a clinical symptom syndrome of niacin deficiency, and those rates of that is quite low, about 5%. We don't see that very often, but being aware that that risk, if you've got Carcinoid Syndrome, might be there. Trigger foods, they're very individual, so don't feel like if someone tells you they need to cut out a certain food and it makes them feel better or helps their flushing or diarrhoea, that's also a situation for you. It may be, but the really best thing to do is be aware of your own symptoms and exactly what's happening. And we suggest patients do this through a food and symptom diary. So that's recording basically everything you're eating and drinking for a period of 2 weeks at least. You should do it as you eat and drink, because we do forget a lot of the little snacks and drinks that we have over the day. And I've got a picture on another slide of a really good diary you can use. And then write the symptoms you're experiencing and see if there's any correlation in terms of those. Some general triggers that we do know generally are able to help people in terms of managing their nutrition and these symptoms. Meal size, so smaller meals are always tolerated better, and you should have some lessening symptoms if you have a smaller, more frequent meal pattern. Fat content, so really fatty foods are often best to avoid. You can still eat fat in your diet, and that's really important. It's an essential nutrient to have, but try not to have really large volumes of fatty foods. Again, with spiced foods and alcohol, high quantities of these can often exacerbate symptoms as well. Then we come to the trigger foods, which are the amine foods. So foods that we know contain amines, and there's a little bit of a complex list there. These are ones that I'm pointing out to you to be aware of. When you do your food and symptom diary, have a look at these specifically and see if any of these, if you do eat them, might actually be exacerbating your symptoms. But I certainly don't want to encourage everybody to cut these out, because at the moment we don't have a lot of evidence specifically to say that these foods will make you feel worse. I just thought I'd put in a few little tips for fullness and bloating, because it's certainly one of the common symptoms that patients come to me to manage, and it can be really uncomfortable. Same if you get a lot of wind. There's natural gas-forming foods in our diet like onions and garlic and cabbage. Reduce those if possible. Things like fizzy drinks, you're basically gulping air that's only going to bloat you and make you feel worse. Smaller meals, again, will really help, so there's less for your body to sit there and digest. And how you choose, sort of trying to not gulp all your food and eat slowly, really helps. Fullness and bloating can indicate other medical problems, so if it's really persistent, you really should mention it to your doctor, just as a disclaimer. In terms of food intolerances, also get asked about this a lot, so often misdiagnosed. I think a lot of patients get told that they might be intolerant to a food even well before they're actually diagnosed with a NET, and sometimes this is actually incorrect, or sometimes it's probably not the right kind of information for you. So food intolerances are commonly associated with things like diarrhoea, abdominal cramps or bloating. Food and symptom diary is the best way to figure out if that's specifically what's happening with you, and that's what dietitians will use to figure out whether you've got an intolerance, and also a very individualised assessment with a dietitian. So a gastrointestinal dietitian or an oncology dietitian, even if they're not a NET specialist, can help with these sort of working through different food intolerances. It's very anecdotal, like Simone said, the evidence we've got at the moment, so we're basing off what we hear day to day from patients about what they might be commonly intolerant to, but we're really trying to find more information through research to help guide our practices. I would really encourage to try and have a balanced diet, so if you are cutting foods out because you think they're making you feel worse, that's okay, but check it with your doctor or dietitian. And try not to severely restrict, so try not to restrict multiple different major food groups, because then you're not going to get your essential nutrients. Unicorn Foundation has a really handy food and symptom diary on their website, so you can download that. It's a PDF and print it and fill that in over a period of a couple of weeks if that's useful to you. bit about diarrhoea. So also quite a common symptom that comes up, and it can be very multifactorial, meaning there can be lots of different causes of diarrhoea. I've written a few there. So surgery, hormone secretion, your treatment, somatostatin analog treatment can cause diarrhoea due to its impact on the pancreas and sort of insufficiency of that. Or it could be a food intolerance, absolutely. Again, little and often, that small frequent meal principle is sort of coming up quite commonly, isn't it? In terms of fibre, so the visible insoluble fibres, so think of these as the fibres that you basically don't digest. They're the skins and seeds and rough grains in your diet that pretty much pass straight through your gut. And if you've got a really sensitive gut that's inflamed and you have diarrhoea, they're only going to make you feel worse. So try and avoid those if you can, but nice healthy soluble fibres in your oats or fruit without the skin are absolutely fine to have. Steatorrhea, some of you might have heard this term before, so this is your bowels when they're floating or they're oily or they smell a bit different or they're more pale than usual, and that's an indication that there's too much fat being passed through your gut and not being absorbed properly. So if you're getting those symptoms, tell your doctor straight away. It could mean that your pancreas isn't working properly to digest the fat in your food. So the pancreas normally releases enzymes that do that pretty well. And if it's not doing that, which can sometimes be due to being on a somatostatin analog or octreotide lanreotide injection, that can be a problem. So that's easily addressed by taking the enzymes orally rather than relying on your pancreas to release them. The fat-soluble vitamins, which I'll talk about, can be deficient if you're not absorbing fat properly, and these are essential vitamins. Probiotics may help. I get asked a lot about probiotics and the microbiome. So some of these may help control if you've got a bit of an imbalance of your bacteria. But if you're on chemotherapy, just be wary of this. And in terms of fluid, if you're losing a lot of fluid through diarrhoea or vomiting, it's really good to take electrolyte replacement drinks if you can. And make sure you're replacing any fluid that you lose. So more about fat malabsorption. So I mentioned that somatostatin analogues, particularly if you're on them long term, can cause insufficiency or poor function of the pancreas, because by reducing hormone function, which helps your symptoms, it can also reduce that pancreatic enzyme release and cause fat malabsorption. In terms of what we know about the data, so your fat-soluble vitamins are A, D, E and K. They're essential for health. In a couple of small studies that have looked at patients on long-term somatostatin analogues, 50 to 80% were deficient in at least one vitamin, but the results we've got for vitamin D may not actually be that different from the general population, so being aware of that. And these are very small studies, so we still need a lot more data looking at the vitamins, and hopefully we're working on that soon. Try not to avoid fat. So a lot of people say, well, I'll just stop eating fat if I'm not absorbing it appropriately, but then what you're not getting is your fat-soluble vitamins in your diet, so that's really important. So the pancreatic enzyme replacement therapy that I talked about, so the enzymes that you take orally, are what are actually going to mimic how the pancreas releases enzymes, help that fat absorption, help the absorption of your essential nutrients, and also make you feel better, make your diarrhoea improve if it is steatorrhea, and also make sure you're absorbing everything you need to. Really importantly is take these immediately as you start to eat. A lot of patients take them post-meal or take them sort of halfway through a meal or before a meal. They only act for about 15-20 minutes, so if you take them as soon as you start eating, they should cover all the fat in your food. And take them at snacks as well. If you are having a milky drink or something that contains fat or nuts or something like that, that's important. Just eating foods rich in these vitamins isn't going to solve the problem either, so I just wanted to mention that, but there are a few healthy foods that are still good to incorporate into your diet if you can. In terms of monitoring, I've sort of talked a bit about the fat soluble. B12 is another one that might come up, particularly for patients who've had bowel surgery. B12 injections may be required, so check with your doctor if you are someone who's had bowel surgery, or if you actually don't eat a lot of meat or are a vegetarian, might put you at risk of B12 deficiency. If you have Carcinoid Syndrome or you're on treatment for it and you might be worried that you might have niacin deficiency, so it's very safe to take a small dose of a B vitamin with niacin in it, but check with your doctor before you do so. And iron, again, if you don't have a lot of meat intake or you've had major bowel surgery, might be a problem. So a little bit to finish off about what my PhD is about, and hopefully we'll be addressing some of the gaps in what we know about the evidence in terms of nutrition and NETs. So the aim of my PhD really is to describe the impact of GEP-NET. So we're looking specifically at gastrointestinal NETs, and their treatment on patients' nutritional status, so malnutrition, and also their quality of life. Hopefully through all this we'll be able to generate some evidence for nutrition guidelines, and I'm really hoping in the next few years, in collaboration with other dietitians around the world, we can actually develop some really clear guidelines for clinicians about how best we can manage nutrition. The first part of the study, of which some people in the room were part of my study, the first one, is a 6-month study, so essentially collecting lots of data from patients who were attending 2 hospitals in Melbourne, so Peter Mac and Austin. So every 2 months they participated in data collection. So that's checking their weight, getting them to fill in questionnaires about their diet and quality of life, measuring their nutritional status. We did blood tests to measure vitamin levels, and we did interviews as well. I also spoke to health professionals as part of the second phase, so figuring out what are our practices, and this is not just dietitians, this is doctors, lots of different kinds of doctors, nurses, and this is around the world as well. So we did an international survey to see what knowledge was like in nutrition and what practices were like, and I'll mention that briefly. So who was involved in the first phase? We had 61 patients recruited over 12 months. Data collection's almost finished. So average age was about 60, a little bit over half were male. As you can see on the table, there's quite a variation in different grades and types of NET tumours that were involved, but all gastrointestinal origin. And a lot of these patients were referred to Peter Mac, for example, for specialist treatment, so they've already had treatment elsewhere. So I've just listed some of the treatments people had already been having at the start of the study. These are some of the symptoms. So this is basically at recruitment. These are the symptoms that these patients were experiencing, and gives you a little bit of context to the prevalence of these, so how commonly they're occurring in this group, but also whether some of these might be impacting the rest of the results as well. So abdominal discomfort really high, bloating, common as I mentioned, I do hear that a lot, fatigue, diarrhoea is up there, and pain. In terms of some of the stats and in terms of what was happening, so almost a third were malnourished, so we did a validated assessment of malnutrition. Less than that, we're seeing the dietitian, so we really need to kind of bridge that gap. The even larger gap was that over half were actually making changes to their diet because of their neuroendocrine tumour or treatment. And so there's a huge proportion of patients making dietary change but who haven't had contact with a dietitian. So I think what we need to do is look at why people are making those changes, and we're doing that through some of our interviews, where they're getting their information from, making sure it's reputable, but also guiding us to sort of increase our information needs for patients. And then there's a bit of information about what they were avoiding and what meal pattern changes they were making as well, which is interesting. And so of the ones that had a dietary change, 50% were avoiding foods. So I think a high proportion that are doing this without advice from a dietitian. What happened with health professionals? So we had 70 or just over 70 from around the world participate, in mostly medical, nursing and dietitians. Where did the responses come from? So most from Australia, probably mostly because I know most of the Australians, but next up was UK, was quite a good representation, and then wider Europe, and then a little bit from the US and Canada. And a nice mix of medical oncology, gastroenterology, endocrinology as well. Really briefly, what did they say? So we asked them to report what they thought symptoms were burdensome to patients or that were of concern, and it actually correlated a lot with what the patients are telling us, so that's a good thing. It means that they're listening and they're aware of what's of concern to you. Only 38% reported actually screening for malnutrition or vitamin deficiencies, so probably lower than we would want, and an area for us to therefore educate health professionals and say, all right, maybe we need to actually have a bit of a consensus worldwide about how often we're doing these things. Of the vitamins they did screen for, it was things like vitamin D, folate, B12 and niacin, which we probably would expect to a certain extent. Just wanted to summarise a few key points to take away from today. So if you're feeling well, you don't have many symptoms, please just eat healthy and don't worry about following a special diet for cancer or anything like that. Just try to maintain your weight and eat a balanced diet. If you've got a really high symptom burden, you've got symptoms troubling you, definitely talk with your doctor about that, but also a dietitian might be able to help in terms of managing those symptoms in a dietary way. If you're worried about food intolerances, do your food and symptom diary and bring it to a dietitian, whether that's a NET dietitian or a GI sort of trained dietitian. And risk of vitamin deficiencies, I've given you a little bit today. If you think you might be on that group of patients that are at risk, talk to your doctor or dietitian in terms of how to manage that. And if you've got carcinoid syndrome, a B supplement may be beneficial. There's some nutrition and NET booklets up the back that the Unicorn Foundation have developed, so just to plug that because that's a really nice general resource on nutrition that we've currently got, and just to acknowledge sort of support for the research I've done. And I'm happy for people to email me if they've got any questions. Thank you.